Virginia has a particular interest, I think, in reproductive issues, and we especially use her as someone that we go to get advice and information about all these issues, and she participates a lot in POSHEAD events. She also is the chair of the POSHEAD Advisory Committee. So I'd like to welcome Virginia.
Thank you, Susan, and thank you to the organisers for inviting me this morning to speak. I'd also like to thank Asher and Jeannie for highlighting the issues around risk perception, and because I'm going to focus on just the biomedical aspects of risk, and so it's very good to be reminded about the other aspects of risk. So excuse me for not addressing any of that. As you know, I focus also on the care of women with HIV, and again, just to raise awareness that the majority of people we're talking about in heterosexual relationships currently globally are women and who have HIV, and also the fact that 32% of women globally will have no access to antenatal care, and that particularly in sub-Saharan Africa, many women die at the time of having a pregnancy. And so when I'm talking about issues today relating to biomedical technology, the vast majority of the world does not have access to this. So I'll introduce you to a new acronym. I'm sure you're already aware of ART, and I'm not talking about antiretroviral therapy. I'll skip through some of these in the presence of brevity of time. So when we're looking at ART in 2012 and HIV, we're talking about assisted reproductive technology. And so we'll be talking about that. I'll be talking about that during this presentation. The aim that we're looking at today is for discordant heterosexual couples to achieve a healthy HIV-negative child, and for the negative partner to remain negative. And so that's the focus of the technology. Obviously, it's a given that for all heterosexual couples that preconception counselling and care should be offered, and that this should be revisited at various times of their attendance at any clinical service. And so I do encourage a team approach in providing this option. In previous presentations and surveys, it was established that perhaps up to 56% of couples never get reproduction discussed with them in the course of their care in HIV clinics. So, and for the woman with HIV in a discordant relationship, then obviously there are going to be many aspects that need to be addressed by their healthcare provider, be it contraception, looking at how to achieve a safe pregnancy, and to treat and stabilise all medical conditions. And so it is also important that for discordant couples, whether it's a woman with HIV or a man, that their partner also is able to attend the service and to receive testing, counselling and care. For women with HIV, there's also increased risk of infertility, such as 40% of women in one particular study had tubal factor infertility. And so one of the aspects that some of my patients need to face is infertility. And so we're increasingly utilising the wonderful services at IVF programs. And so for a number of couples that I see, they currently attend the Royal Hospital for Women, but also there are services obviously at RPA, at Westmead, John Hunter, and as I'll tell you about also in Melbourne. And so infertility should be something that can be addressed for all heterosexual couples if it's relevant. It's also not just about HIV and the impact of HIV. For many discordant couples that I see, they're also, the biological clock is ticking for the woman, whether or not she has HIV. And I see a number of discordant couples I have seen this year who are in where the woman is in her early 40s. And so there are other dynamics that the couple has to consider, such as the risk of Down syndrome. And you can see here, as the woman is getting older, that risk can certainly, for trisomy 21, and all trisomies, trisomy 21 is Down syndrome, then that risk is also something that the couple has to be advised about. Okay. So what I talk about now is a new ethics of HIV care. As we know, people with HIV are going to have a normal or near normal life expectancy, and accompanied with the significant decline in the rate of mother-to-child transmission in developed countries, then it means that discordant couples should have access to assisted reproductive technologies without discrimination. In some jurisdictions, ethical and medico-legal issues continue to be debated, particularly in the United States, where they may not be able to readily access ART. And I'm aware of a small number of patients who have been denied access to ART in their local health service. It's difficult to estimate the exact demand for ART. At one particular audit, which was conducted some years ago now, 16% of men and 4% of women, heterosexual men and women, inquired about fertility treatment. And obviously there may well be other additional patients identified as with HIV testing as part of ART programs. So when we're talking about discordant couples and the potential use of ART or advice regarding harm minimisation or risk reduction in terms of the negative partner, there are three potential scenarios. So whether the male has HIV or the female has HIV, but I'd also just throw in there, though they're not discordant, that there may be certain circumstances where both couples have HIV where risk minimisation may be relevant. So in terms of options for conception, for many couples it may relate to unprotected sexual intercourse, and I'll talk a little bit more about that. For couples where the male partner is HIV negative and the woman has HIV, then specific advice and assistance can be given for them to have home insemination. So there's no major drama in terms of achieving a pregnancy where the male is HIV negative. However, obviously if there are issues concerning infertility in one or other or both partners, then assisted reproduction with AI or intrauterine insertion or IVF or ICSI may be required. So as I said, where the male is HIV negative, their first option is looking at home insemination, and it's ideal if that happens when the male can masturbate and ejaculate and provide semen to be just shot into the vagina at the estimated time of ovulation. Now this process is not for everyone, but most of the couples I see in this discordant situation do try this. However, the success rate is unknown, and I do see couples where they do not achieve a pregnancy. It's important to assist the couple to look at the time of ovulation with an ovulation kit or thermometer, and to also have an assessment of perhaps aspects relating to infertility, irregular periods, particularly if the woman is older. And in this situation, if the couple are not achieving a pregnancy, or even prior to embarking upon this process, perhaps a sperm, I usually do a sperm count, that may be useful as well. It's been estimated that in this discordant situation, it may take a median time of 5.2 months for the couple to achieve a pregnancy, and that's with quite frequent intercourse. Now, the challenge lies in seeing discordant couples where the male has HIV and the woman does not. And obviously, one option for this couple is unprotected intercourse or the use of ART. Other aspects I've put in brackets because over many years of seeing many discordant couples in this situation, no one has opted for donor sperm, no one has talked about adoption, and no one in this situation has so far embarked upon surrogacy, although I do see a number of gay men who have embarked upon surrogacy to achieve a pregnancy. We are all aware that the risk of HIV transmission between heterosexual couples is estimated to be 1 in 1,000. And this is a very, very early report showing that in 104 consecutive pregnancies followed over 10 years between discordant couples, there were 4 seroconversions in that study. However, this was in 1997 and times have moved on. And so there are many other aspects now that we can consider that we can offer a couple to minimise the risk. And so, as we're all aware, what is happening is that as people are placed on antiretroviral therapy, we see reductions in transmission. So the evidence of treatment as prevention, initially it started to come from community viral load and the reduction in new cases of HIV. This is San Francisco, which was reported in 2010, and this particular observation is ongoing over time. But more relevant to couples where the male has HIV and the woman does not is the HTPN 052 study that's already been spoken about, which Dr. Cohen and colleagues showed a relative reduction of 96% in the number of linked transmissions in the discordant couples. So it wasn't 100%. And I guess for many of the discordant couples that I see, there is this lingering concern that I cannot guarantee them 100% safety with unprotected sex. So with the studies and with the Swiss statement that people who are on treatment are no longer infectious, is this safe? Does this give discordant couples an opportunity to have unprotected intercourse? And I guess all I can say is we can't make the risk zero, and there are many potential factors that I cannot weigh up for the couple in terms of the safety of unprotected sex, such as the degree of infectivity. Many of the studies are not adequately powered to provide us with meaningful information. But in many of the studies also, particularly the PrEP studies, focus on adherence as being a key element to achieving, to eliminating transmission. As we know, STIs also will increase the risk in the couple. We can't assess the impact of male circumcision. You're all aware of the studies that show that circumcision reduces the risk. And the impact of PEP and PrEP. It is not very practical often to offer discordant couples PEP and perhaps in the future PrEP, but it is available. But because it means that the couple, the negative partner, may need to be on continuous antiretrovirals, perhaps for 6 months or even longer. And that is often not acceptable to the negative partner to do that. But it is an option to minimise the risk. So it's very complex in terms of being able to assess what we can offer these discordant couples. In addition, we have a lot of data now. This is a previous data presented that shows that there is often a discordance between the viral load in the plasma and the viral load in the semen. And one of the elements that contributes to this is the fact that the antiretroviral drugs will penetrate into the seminal fluid to different extent. So we can't guarantee that just because your viral load in the blood is undetectable that it's also the case with your semen. We can do semen viral loads, and that may assist in some couples. So this whole issue has become more and more complex. Okay, so in terms of a discordant couple where the male has HIV, the bottom line is, can we recommend the unprotected sex if the patient is on HIV treatment with an undetectable HIV viral load? I guess all I could conclude is, in practice, it may be possible to consider this for individuals and for individuals to make their own informed choice, but it's not something we are yet recommending at population level. So if we're looking at safe conception, then we're looking at ART, assisted reproductive technology, and that may be, as I said, through sperm donation or through sperm washing and IVF. Now, sperm washing for discordant couples is available in Melbourne. It's not yet available at the Royal Hospital for Women, but a colleague, Liz from RPA, has indicated that sperm washing is currently being undertaken in certain situations at RPA. So it's something that we can further explore, but it's not readily available universally in New South Wales. In Melbourne, at the Royal Hospital for Women, there is a dedicated team that utilises assisted reproductive technology and sperm washing, and the patients go through this program. It is quite an involved process. It may take many months. I've had a couple of couples go through the process, and it took 18 months to complete the process, and one couple achieved a pregnancy and one did not. There is not a guarantee that even with ART you will achieve a pregnancy. There's a sperm washing process which I won't have time to go into, and even with this process the pregnancy success rate is only 10 to 20%. But certainly there have been no documented transmissions through more than 5,000 cycles of IVF. Okay, so in cases where couples have infertility, there are a number of processes that can be offered through an IVF service. One of the prominent processes is called ICSI, intracytoplasmic sperm injection. And there is limited data in HIV-infected women, but Van Leeuwen and colleagues have published in 2007 looking at 127 women with HIV, and their pregnancy rate with those women was 17% per embryo compared to 26% with the general population. So it's again not a guarantee of success. And again, looking at ART, there is a slightly different rate in using intrauterine insertion versus a more complex procedure like ICSI. So the pregnancy rate is slightly different. So ICSI is using technology, it's a magnifying microscope, where in essence one single sperm is picked up on the end of a needle and injected into the egg, into the ovum, and then you can see that the beginning of life and the cell division taking place. So in terms of ART in HIV serodiscordant couples, most of the work has been done in Italy and in Spain. Very little has been done in the United States, as you can see. And there have been lots of reported outcomes published in the literature. This is only up to 2005, which was reviewed by Michelle Giles from Melbourne. And through all of those particular publications, there were no HIV transmissions. So that's at least a very comforting result. So in general, the principles of care in providing reproductive options for couples with discordancy have been well enunciated by Michelle Giles, and they basically revolve around open discussion of options and parenting with couples, always adopting a non-judgmental approach and provision of up-to-date information, and wherever possible being able to provide access to all the available options, including assisted reproductive technology. And it behoves us to continue to report the outcome data to be able to provide information for patients into the future as we move through with providing them with this assistance. So I thank you for your attention, and I welcome any questions.
So,